Good morning, everyone, and thank you very much for this opportunity to come and talk to you today and to hear all the fantastic presentations of yesterday and the ones I'm looking forward to for the rest of the meeting. Given the audience, I don't think I need to explain what a mathematical model is, but what I'd like to do is focus on I think we've seen a lot of really beautiful research showing the methodologies of how to move from the real-world data to excellent simulations yesterday. And what I would like to do is focus on how do we get that information back to being used in the real-world scenario. And what I'm going to focus on is malaria elimination. This is something I've been working on for the last 10 years. And and this is a huge team effort, and you'll see pictures of various members of my team as we move through the presentation. And I'm going to use the World Health Organization strategy until 2030 as a kind of framework to show how modelling can be applied to each of these pillars and supporting elements with examples from work from my group. So let's start first with universal access, prevention, diagnosis and treatment, and accelerating efforts towards elimination and attaining malaria-free status. So this is what used to be called the control phase, and this is called the pre-elimination phase. So the control phase is where malaria force of infection, where malaria incidence isn't really changing, but what you're doing is you're at least finding as many clinically ill people you can and treating them. But what you're not doing affecting the force of infection or changing transmission. And you're also providing people with prevention either through spraying insecticide in their homes or providing them with bed nets to sleep under. And then this is the basic building block. This is the foundation of any elimination strategy. Without this, you can't do this. And, but this usually needs different strategies, and those strategies will be tailored to the transmission setting that you're looking at, the country, the resources, the malaria situation that they have at the time. So here's something that it would be lovely if you had a look at. So what I'm showing here is a web interface of a mathematical model that we produced, and I did this in collaboration with Sheetal Silal, who has her own research group in the University of Cape Town in South Africa. And so this is an example of a very broad stroke policy-making approach. We had 1 year to basically use mathematical and economic modelling to propose strategies for eliminating malaria in the entire Asia-Pacific region. That's 22 countries. And at the beginning of that year, there was a lot of management of expectations that had to happen in terms of what we could achieve, starting with a few models that we've been toying around with to getting to this point where we have a multi-species, multi-patch economic epidemiological model for a large region like this. And it was based on WHO data. So these are, if you went to each of these countries individually, you would see a much more detailed data set than the one that they use to report to the WHO. So they keep their own records in far more detail than is required by the WHO to sort of feed into their World Malaria Report. But we didn't have access to that. We didn't have time to form individual relationships with each of those countries. So we relied on the WHO data. And that's why we have these, this kind of prediction interval and uncertainty in the model output that we provided. We ran the model this many times for all of these scenarios, multiple scenarios for different countries with different packages of interventions for malaria. And we pre-ran it all. So this is an example of an interface that gives it gives the feel of running a model, because the user will go in and they will pick different sets of interventions, they'll pick different countries, and they'll press go, and then they'll see the model output. But actually, it was all run in advance. We have other interfaces also using R-Shiny, where the model is run live, and but this one takes too long. So I think by the time they pressed go and then had a cup of tea and came back, they'd be bored and wouldn't want to look at our model. So this was the solution we had. Relatively simple model that underlies all of this, especially compared to some of the ones we saw yesterday. So it's a set of ODEs, and I'll take you through the structure of those, and hopefully I'm not going to talk too deeply about the equations themselves, but about the natural history of infection of the two diseases that we used to create this model. So the first one is Plasmodium falciparum. Now, I'm not sure how familiar with everyone is with malaria in the room. It's a vector-borne disease. It infects your blood. There are 5, actually, species that infect humans, and one of those species also infects monkeys. But the 2 main species are Plasmodium falciparum and Plasmodium vivax. And usually in most African settings, they only have this one. So most of the malaria models you'll see in the literature are only PF. But in South American settings and in Asian settings, there are all the other species as well, and the main one that's secondary to falciparum is vivax. It's secondary because it doesn't kill you as often, but actually it's more prevalent in a lot of places, especially places that are good at controlling malaria. So that's the structure for falciparum. So we start with uninfected, non-immune individuals. They become infectious. They recover, they become immune. So it's your standard SIR model, except it isn't, because people lose their immunity to malaria. Also, we have to know what type of infection those people have, because if you're clinical, you'll go and seek treatment, and you'll appear in the surveillance system. And so we'll only see a subset of these people in the surveillance system in routinely collected data. If you're asymptomatic, you won't seek treatment, but you'll still be very infectious for quite a long period of time. They think maybe up to a year. Here, you're still infectious, but you test negative with all the usual tests, the rapid tests. So you continue being infectious, but you're even testing negative at this point. Or if you're clinical, you can become severe and you can die. So a standard approach, you either get treated when you get a clinical infection, or you go up the level of severity, get really sick, or you go, you gradually, if you're not treated, you gradually eliminate your parasites and you move down the levels of severity and eventually recover. But if you're treated, then you're going to appear in the national surveillance system, unless you go to a private facility, in which case you won't appear. So we're really seeing the tip of the iceberg in terms of the data here. We're working very much in the dark with malaria. Another interesting feature is that if you get treated, some of the rapid tests, they actually work on a protein that's produced by the infection, and that protein sticks around longer than the parasites, so you can test positive when you're not actually positive. And then you clear your infection. Not the end of the story, though, for malaria. And by the way, I've been criticised that this is an overly simplified model. So this is the simplest one we could think of, and we've been told off repeatedly for being too simplistic. So if you're immune, you can still get infected. So there is never at any point in your life, if you're in a malaria endemic zone with mosquitoes biting you, there is not a single time when you couldn't become infected by malaria. So you can be reinfected when you've just recovered. You can be super infected while you're already infected. And some ways to measure prevalence in a particular area is to look at the multiplicity of infection in individual people. So you're actually looking at, you look at an individual, a bunch of people, and see how many clones of the parasite they have in them during their infection, and that gives you an idea of how much malaria there is around in that area. So we need all of those processes. We need all of those hidden parts of the system because some of the interventions are going to act on these hidden parts as well as on the parts that we can see. And if you increase treatment, you're going to increase reported cases. So if you're not aware of this relationship between your intervention and the surveillance system, it can look like the intervention that you're doing, which is actually reducing malaria, is giving people malaria because you do more treatments, you see more cases. So that's it's something that you need to be aware of in these sorts of systems. Okay, so that's one of the species, but the control programs, the international donor community, and the people who are catching malaria don't care which type of malaria it is. They just don't want to have malaria. So we have to model Vivax malaria as well, at least. So that one's more complex than the other one. It's less studied. And the key difference is this stage here, which is the hypnozoite dormant stage. So in Vivax malaria, not only do you have all of the other things that happen with falciparum malaria going on, you also have a stage of the parasite that remains dormant inside your liver. And even if you move to the moon, you could potentially, and you never get bitten by a mosquito ever again, and you treat your blood stage infection, you can get malaria again and again because these dormant phases wake up. And that makes Vivax a lot harder to get rid of than falciparum. So now we have two, but actually we can't, ideally you would model them both separately because that's just easier. You just treat them as completely different diseases and model them separately. But you can't because the treatments that work for one species also work for the other. So if I have a clinical Vivax infection and an asymptomatic falciparum infection, and I treat my Vivax infection, I clear my falciparum infection as well. So the species interact with each other. So we must have them together. So I could go into the way that we made a shortcut for how to only have twice as many equations rather than multiplying the two sets of equations. Be happy to discuss that, but I don't have time in this presentation. So I am going to talk about all the other things we had to put into this model in that year. So first of all, we had to produce a spatial element for the model. And because of the talk yesterday with Sarah, I think we can go more quickly through this. So this is a multi-patch model. So you need the population distribution in your patches once you've defined your geographical scope. And then we need to understand the connectivity between those patches. And for us, we didn't have the data on flights or travel or population movement. So we just assumed essentially a gravity model. So the nearer the patches are, the more likely they are to be connected. The higher the population in a particular patch, the more likely it is to be connected with all the other patches. Then you need data on the disease itself, the incidence of the diseases, and that's heterogeneous. So we also have information on historical interventions. So we're not going into this where from a sort of starting point where there's no control. So every country has already done very well at controlling malaria and are at different phases in their stages towards elimination, and we have to acknowledge that because if we can't recommend maximum detection and treatment of clinical cases if they're already doing that. So we have to know where they're at and why the incidence is at the level it's at. So if you've got low incidence, then is that because you have a low biting rate, or is it because you're really good at controlling malaria? So we need to know, because it has implications for the strategy we recommend. Same for vector control. So this is mainly in the form of distribution of bed nets. So how many people are sleeping under a bed net? How long do the bed nets last? How often are they distributed? And then we've got our model already that we discussed earlier. Then we replicate it and wire it up in the same way that I think a lot of people have been doing. And so that we did it in R, but it would probably be better to do it in a faster language. There are bits of it. So there's R is the sort of shell, but there are parts of the code that have been written in C that are calls. Okay, so first question that we're asked by policymakers is, what's the potential impact of a given strategy? And they usually have a bunch of strategies on the table, and they want to compare the potential impact of each of those strategies. The next question is always, well, how much is that going to cost us? Can we afford it? Is that actually feasible to do the strategy we want to do? And for that, we have to incorporate cost into the model. So we need outputs in terms of when we're modeling, increasing the coverage of bed nets, then we need to add up all the bed nets we've simulated increasing it by, and then have a unit cost for those bed nets, distribution costs, all of these costs that are associated with doing that, and make a prediction on that. Now, that's fine with interventions that are already in place. Sort of fine. You still have to, the costs are different for different countries, and someone has to go and collect those costs. But at least the data are there. But what do you do for proposed interventions? How do you cost those? Something like mass drug administration in Asia. So that's where you give everybody, regardless of their symptoms, regardless of their testing. You don't test them, you just give everyone the drugs. And with the idea that if you give them to everyone, you're getting rid of the parasites in the people that are carrying them, and you're giving the people that aren't carrying them a period of prophylaxis so that they can't be reinfected. So mass drug administration is on the table for malaria in Asia, but nobody's done it before. There's a few trials, and so in those trials, trials are extremely expensive because you have the burden of proof, and there's also a lot of other research that goes in partnership with the trials that would not necessarily be done in a programmatic rollout. So Shui Sin Chor, who is a PhD student of mine from Myanmar, has developed an ingredients-based costing model where she takes the financial data from a trial and she breaks it all down in terms of the cost of the trial, and then you can build it back up again and choose which bits of that trial are going to be relevant for a programmatic rollout and which bits are not. And she's also created a web interface because not everyone agrees on which components are just for research and which ones are for programmatic rollout. So we didn't decide, we let the user decide. And each user will choose make a different choice. But what we can do with this approach is come up with a cost associated with interventions that are under trial but haven't been done yet, so that we can project that cost if we include that in the package of interventions. Okay, so that's that bit. So transforming malaria surveillance into core intervention. Okay, so this is a current student of mine, Peng Bee Ngor, who's in Cambodia. And this is him taking a photo with the first, I think, 20 village malaria workers with whom we trialed a smartphone application. So at the time, smartphones were considered too expensive for handing out to village malaria workers, because in Cambodia, I think there's thousands of village malaria workers. So these are people that live in villages. They go about their normal business, their work, but they also volunteer to test and treat people who have a fever. So if people have a fever, they go to their village malaria worker. Their village malaria worker does a test, a rapid test on them, and if they test positive, then they get a treatment. There have been problems with stockouts. There have been problems with delays because there was a paper system, and the paper system, as you can imagine, took months to get the data from the village malaria workers, sometimes in villages where you had to sit on an ox cart for a day to get to that village. There was no other way to get there. And some of them you have to ride on an elephant to get there. So they would collect these paper documents, and then they'd give them to someone in malaria head office, which used to be Peng Bee, who would type in all of the data from the paper. And so what he's done is he's created this beautiful smartphone app where the patient comes in, you open the smartphone app, you say whether they're male or female, you put their age in, they do the test, you put in the test result. I can't remember what that screen is, but then you press go, and that data point appears immediately in the head office database. And it was trialled for 20 individuals, it's now been rolled out across the entire country. The reason why I'm telling you this story is because now that they have real-time data reporting, they can intervene in close to real time. So if a case comes up in a village, they can decide at head office what to do about it. But the question is, how do you decide what to do about it? And that's where modeling comes in again, because they now want to add a modeling overlay to their dashboard at head office to say, okay, what are the strategies, what are the most effective strategies to use with this brilliant new real-time surveillance system? We know we get the data right away. What do we do with it? What strategies can we deploy? Well, let's use an individual-based model to decide. So that's something to speak to that part of the strategic plan. Harnessing innovation and expanding research. I think this is my favorite part. I enjoy the ability to have an impact with the interaction with the policymakers. But this is where we get to incorporate modeling research into a feedback loop with scientific inquiry. And so there's a couple of examples of this that I've shown here, but there is an opportunity, and we've had opportunities to interact with laboratory and clinical researchers who have a specific question. In this case, the specific question was, what is the impact, what is the potential impact of poor quality or counterfeit medicines on the spread of resistance to malaria treatment? And May and myself are working with a team at Washington University, Georgetown University in Washington, to actually really explore in the lab. We're modeling now not only what happens in the population under different assumptions about the relationship between medicine quality and resistance, but also we're going back to the lab and getting more data. So we have a version of this model which simulates what happens in the lab in silico, and then using that model to inspire new experiments, which then feed data back into the model. It's very satisfying project, that one. And this one is an exploration of what are it was a within-host model for malaria infection, falciparum malaria, under treatment. And what we were trying to look for there was what was the most likely stage of the infection that was being affected by resistance. And we predicted something that that turned out to be the case with future experimentation. So, strengthening the enabling environment. So, when I started working on malaria modeling in the Asia Pacific, I realized very quickly that the Thai culture, where I was based, I've moved to Oxford since then, but I was based in Thailand for 12 years. The Thai culture and the Thai language and the Thai Ministry of Health and the Thai Malaria Control Program was very different from its neighbor in Cambodia, and the Cambodian system and the Cambodian language and the Cambodian culture and their malaria control program, which was very different again from Laos, from Myanmar. And I quickly realized that I preferred this option, where instead of me trying to understand and absorb basically a lifetime of culture and understanding of a system, that it would be easier for me to teach modeling to more people. And I'm very pleased I did that. And the result is that there is a new cohort of malaria researchers who use modeling in the Mekong region. And so I could give you stories about each of these people, but I would definitely want to do more of that. It's so efficient. Once people understand the modeling side of it, they already know what the key questions are in their own countries. A lot of these people were recruited from the system. So Pengbi, for example, worked in his control program. Shui Sin worked in an NGO that dealt with health and malaria in Myanmar. Jahirul was, at the time, was head of the malaria control program in Bangladesh, so he definitely knew what the questions were. Sheetal was an academic, but she has a very close relationship with the National Control Program in South Africa, and has had an enormous impact very quickly after gaining more skills in mathematical modeling. So here are some applications of that particular suite of models. Again, a lot of this is, so this is how it's, the initial example I showed you of the Asia Pacific. That's how it started. Australia wanted to have more of an impact on health in the Asia Pacific, and so our research was part of supporting that decision making. There was a series of investment cases written by my colleague Rima Shretter, who was at the time at UCSF. I think that's another missing piece of the puzzle, actually. So I think to have real, my opinion, but I'm happy to debate it, is to have real impact with modeling research. You need the technical skills, you need the mathematical modeling, you need a good model of the diseases. You need to have a good question, the right question to answer. So the question might not suit your model. So don't try and make the question suit your model. Try and make your model suit the question. And then beyond that, you need cost. That's the bottom line. Money is the bottom line. You need cost. And beyond that, you need to be able to communicate those results in the language of the decision makers. You also need to educate them a little bit in your language, especially in terms of the concepts of uncertainty. But I think the key that made us be able to translate this research into action was these investment cases that were written by Rima, who was able to convert all of the technical stuff into political language. And the most recent, we're working on some new regional approaches with the Global Fund, and the most recent one was we were asked to look at was the Guiana Shield region, and obviously because of my connection with Roberto, we have included Brazilian modelers in that activity. So to conclude, I think I said it all anyway, but you need these components. You need to understand the concept. You need state-of-the-art methodologies. You need economic features. One thing I didn't write in here, which I think is important, is you need to do it in time. So there's what you would like to do, like the publication grade, beautiful piece of work with the beautiful model and the perfect data set. And then there's reality, which is that you have to cobble something together in a fixed time period. And if you don't do it, the decisions are going to be made without your input. So you either live with a substandard, what it feels like a substandard piece of work, and join in, or no one's going to wait for you. No one's going to say, oh, well, I won't make my decision until you've done your 5 years of research, you know? So I think that's a really key lesson that I had to learn, hard lesson. And the other enormously important component is communication. How do you communicate? You need to learn other people's languages, and by other people's languages, I mean in terms of the science, in terms of policy making. You need to understand everybody else's perspectives and what they're looking for with the work, and how can you deliver it without compromising your own scientific integrity. I think participatory modelling is something that is a nice way to ensure that that happens, and that means engaging with the person who's going to use your model, or the people that are going to use your model early and continuously throughout the process, so that they go on that journey with you. You don't have to sell a finished product to someone who doesn't know what it is. They've come with you on that journey. They have helped you decide what the assumptions are and why they're reasonable to make. They know what data has gone in and what's had to be glossed over. And they've accepted those things along the way. And so by the end, there's nothing to sell there with you. And I think another way to really nicely communicate this kind of research is with user-friendly interfaces. So have a nice front end to the model so that people can, who aren't modelers, can explore it for themselves and play around with it and see its value, and have outputs that are meaningful to them. I think the really important part is that the demand for this sort of work is increasing and increasing. We need to really up our game in terms of training the next generation. So I'd like to acknowledge all the people that I work with who I've mentioned throughout this presentation. This is my old group in Thailand, who I really, really miss. This is in Bangkok, in our little rooftop garden next to our office, where we would have the occasional cocktail party, which was a lot of fun. And thank you very much.
Thank you. So we have time for some questions. Nico? Yeah, speak up, because I don't want the mic going on.
Okay, so as you said, there are a lot of unseen data. Yeah, like there are a lot of untreated people and also asymptomatic ones that the systems are not detecting. How do you deal with this no information that affects the malaria transmission, but we cannot see?
Yeah, thank you. So you're asking, how do you deal with the fact that you're only measuring a small part of your system? So you only have data on a tiny part of it, but all of those other parts are necessary. Well, there's a few ways. The first way is for that first example, we had a very limited data set, and so we didn't even fit the model because it was not identifiable actually. So what we did was we calibrated. So we chose a swarm of sets of parameter values that were consistent with the observations. And so we attempted to cover the uncertainty by selecting as many sets of parameter values we could in the time that would reproduce those data with the model output. And then we tried the interventions on all of those. That's the way that we dealt with that particular problem. The better way is, as I described before, where you get into this cycle where when you produce a model with a particular data set, that's not the end of the story. You continue to work with your collaborators, and if you identify areas that if only we could measure this, we would have a better model, then there will be people that will measure it, and then you can improve the information that's going into your model. So, and also with working more directly with specific countries, they have more data than the sort of data you see that's collated at the international level. So if you go deeper and collaborate more closely, with the national control programs, you will see a large quantity of data. You'll have information on the interventions that they did. And so if you see how the system was perturbed, and you know how the coverage of how it was perturbed, then you can measure more parameters that way from the perturbed system.
Somebody raised the hand over there. Yeah, first then.
About the spatial model, the multi-patch model, did you wrote any papers about it?
Yes, we finally wrote one, so there's a set of papers at Welcome Open Research, which you can have a look at that basically cover that entire exercise, including the detail about that spatial model. So I could share that with you later.
Okay.
Yeah.
Just a minute. Yeah.
Okay, thank you very much for your presentation. I want to know, because you are in
This is a bit louder.
East Asia, and this malaria SAIFR is also in South African country. Do you extend your project to those continents or also in Latin America? So what do you think? And the second one,
Okay.
this we are doing this to malaria, plasmodium, Bavexana, and plasmodium and so they interact. When they interact, they are a symmetrical interaction or they don't have any interaction. When you do engineering, what are their those two malaria? They interact asymmetrically or symmetrically, or they don't have any interaction inside.
Okay. Yeah. Thank you. Two very interesting questions. So first of all, you're saying, are we expanding the geographical scope of this research? And the answer is yes, but not me, because Sheetal, who is from South Africa and has her own research group in South Africa, is doing it. So she is using a modified version of this model and has used it already to work with the control program in South Africa. And actually it's a really interesting case study, very nice story, is she tried every intervention that the control program wanted her to explore, and none of them were getting rid of these last few cases in her model. So what she did, and they were mostly imported cases, so what she did was she added a patch. And the patch she added was a province of Mozambique. So when she included this part of Mozambique into her multi-patch model for South Africa, she found that the best strategy for South Africa for eliminating malaria there was to reduce the source in Mozambique and to help Mozambique to eliminate malaria in that part of the country. And this was purely a modeling result. She wasn't asked to explore this. She innovated and decided to explore this herself. She gave that information back to the control program, and funds were released in the budget that year, and they're going ahead with that. So I hope that answers part of your question. And she's now doing the same thing, training and building capacity in neighboring countries and other countries in sub-Saharan Africa. And I'm very supportive of that, but she's doing it, she's leading it. The other question was the interactions between the two species, are they symmetrical or asymmetrical? Actually, a lot of them are still only, so we know about the treatment ones. The treatment ones are, we kind of, those are the best known interactions, but there are also other proposed interactions between those two species, and some of them are asymmetrical, considered asymmetrical. So for example, there is the concept of masking or competition, and what people believe, but there is no actual definitive proof that I'm aware of, is that if you're co-infected with falciparum and Vivax, the falciparum outcompetes the Vivax and can push the Vivax down. Also, when you're testing, although there may be genuinely a mixed infection, then you may expect to only see a positive result for falciparum. So there's a few asymmetric interactions, but they are they're exploratory at the moment. So we put them in the model, but we don't really know what they are.
What's the role of the malaria vaccine on the dynamics of malaria spread in the areas that you've looked at?
That's really interesting. So are you referring to the RTSS vaccine, which is the one that's closest to actually happening? So the RTSS vaccine has a short duration of efficacy. So it will last, I think, for about a few years only, if that. And the way that it was proposed to be delivered initially was with the EPI, with the standard infant vaccination program in countries. So if you're vaccinating only infants, which is what, 50, I don't know, like 1/50th of your population, or 100th of your population, with a vaccine that only has a duration of protection of a few years, then you're not going to have any impact on transmission whatsoever. What the economic analyses showed was that it was still cost effective to do that, because you still allow those children to avoid their first clinical malaria case. So it's more in terms of reducing harm, that particular, used in that way. What we have explored is mass vaccination, or using the vaccine in other niche ways in order to change, in order to build it into a package for malaria elimination. So one way is to do mass vaccination every year. That's extremely expensive and unlikely to happen, especially since you need to give 3 doses of that vaccine. Another one that I would like to explore, but we haven't done it yet, is to vaccinate risk groups. So there are people who, because of their behavior, they spend a lot of time in the forest getting bitten by mosquitoes with other people that are in the forest also getting bitten by mosquitoes, and then they take that malaria back to their village and their families. They don't sleep under bed nets because sometimes they work at night, and they're living in sort of kind of very temporary accommodation, if anything, in the forest, sometimes sleeping in a hammock or something. So those people, I think, if they manage to get a dose of the vaccine from their village malaria worker when they were on the way out to do whatever they're doing in the forest, and if they were doing that frequently enough, they'd get 3 doses, but at irregular intervals, then that could protect them for the short duration of time that they're in the forest. So I quite like the idea of building it in to apply to people where other interventions aren't working in the sort of artillery.
A question?
Hello. I'm just a little bit curious about the data that you're using, because I am, well, actually, one particular data, the data from Venezuela, because you circled something around from Brazil and Venezuela also. So I would like to know if you have some information about the data, because I like at least ranges of time.
Yeah, so that project is under negotiation.
Okay.
So we are not sure what the questions are for that particular project. And actually, there's a call that I'm going to join in on tomorrow, about that, where we discuss what are the data sources, what are the questions. What I can tell you is, although I'm not leading this, actually Sheetal again is leading this, what I can tell you is that all of the control programs of those countries, representatives of those control programs, will be involved in that project, and it will be decided at that point how we're going to do that work. But that's all I can tell you at this stage, very early stage.
No, I'm telling you this because I have been working for a while with dengue data and with malaria data from Venezuela, because I have some particular questions that I have about the data there. And I have seen that reports, epidemiological reports, have been good reports until 2014. After that, everything is really messy.
I see.
Yeah, well, again, the data that I managed to collect from the epidemiological data that they published poorly in their web pages. So, but that's why I was asking, in order to have the possibility of comparing maybe the data that I have with the data that you might possibly get. I don't know.
That would be great. Thank you. Yeah, I mean, at this point, we're really doing an inventory on, it's, as I said, very early stages, so there's an inventory going on about what is it that the control programs actually want to do. And so we're reviewing their national strategic programs and reviewing that. We're also reviewing what data are available and how reliable they are. And once we have gone through that process, the next step will then be to decide what we can actually do in terms of the modelling, given the uncertainty in the data and the amount of information that we have. So it would be, maybe we could talk in the break about that. That'd be great. Thank you.
Any more questions? So, okay. Thank you again. Now a short break of 10 minutes, and then we come back.